Thank you, everyone, for joining us. This is the ATS Assembly on Pediatrics webinar. It is on home mechanical ventilation, weaning, and BPD patients. I'm Tiffany Turner. I'm the moderator and will be presenting just a few quick slides in a few minutes about BPD in general. And then I wanted to introduce our great speakers and panelists that we have today. Dr. Christopher Baker from Children's Hospital of Colorado. He's also the director of the ventilator care program for Children's Hospital Colorado. Dr. Juana Cristea is at Riley Hospital for Children, where she is also the medical director of the home ventilator program at Riley Hospital for Children as well. Dr. Jacob Caslow at Vanderbilt University, where he is the director of the tracheostomy ventilator program at Monroe Carroll Junior Children's Hospital at Vanderbilt. Hiram Mazumdar was having a little bit of trouble with some technical issues, but hopefully he will be able to join us. He is from UPMC Children's Hospital of Pittsburgh, where he is also the director of the home ventilator program here at Children's Hospital of Pittsburgh. And then Dr. Howard Panich is from Children's Hospital of Philadelphia, where he is the director of the Technology Dependent Center at Children's Hospital of Philadelphia. And then I have a few quick slides. And then we'll start with our discussion with the panelists. So I have no financial disclosures, although I am the assistant director of the home ventilator program with Dr. Mazumdar here at UPMC Children's Hospital of Pittsburgh. So next slide. And then next slide. So what is BPD? It is the development of chronic lung disease that results from mechanical ventilation and oxygen therapy in premature infants. Next slide. BPD, old BPD was first defined by Northway in the 1960s. It was first defined as supplemental oxygen at 28 days postnatally. Quite considerable time later in 2001, there was further classification by the NHLBI, and then more recently in 2016 by the NICHD workshop. And I'll have two slides of those. Next slide. The NHLBI definition in 2001 focused on the time point at 32 weeks gestation. So if folks were 36 weeks post-menstrual age or discharged to home, whichever comes first, they were assessed at that time frame. If they were greater than 32 weeks, but less than 56 days postnatal age or discharged to home, whichever comes first, they were assessed. Mild BPD was defined as breathing room air at 36 weeks post-menstrual age or discharge, whichever comes first for those folks born at less than 32 weeks. And similarly, breathing room air by 56 days postnatal age or discharge, whichever comes first. It was considered mild BPD for those folks that were greater than or equal to 32 weeks. Moderate BPD was the need for 30% oxygen at 36 weeks postmenstrual age or discharge for those folks less than 32 weeks. And then at greater than the 32 weeks, the need for less than 30% oxygen, 56 days postnatal age or discharge, whichever comes first. And then our focus is going to be on the severe BPD patients, those needing positive pressure ventilation, but the definition does include greater than 30% oxygen and or positive pressure ventilation, whether that be non-invasive or invasive ventilation at 36 weeks post-menstrual age or discharge. And then same for those at greater than or equal to 32 weeks, need for greater than 30% oxygen and or positive pressure at 56 days postnatal age. Next slide. And then this is the NICHD workshop criteria. They grade by grades 1, 2, and 3. We're going to focus on grade 3. Those are the patients that are chronically ventilated or the invasive IPV. It also includes patients who are on greater than or equal to 30% oxygen through CPAP or non-invasive positive pressure ventilation. Next slide. So BPD and chronic ventilation, how do we even get there? So of course, the most common reasons are gestational age, of course, the less than 32 weeks gestational age, or low birth weights. Also early volume trauma, which is those folks that have high tidal volumes or high PIPs early on in life. Tracheobronchomalacia has also been associated with the need for chronic ventilation in BPD patients, as well as nutritional deficits, and there also is potentially a genetic component. Next slide. So some ventilation approaches, the acute ventilatory approach, which is kind of the approach that we don't necessarily see quite as often, although I think more NICUs are consulting pulmonary earlier and earlier. So we may be seeing some of the acute ventilation strategies. But acute ventilation strategies in the NICU include low tidal volumes, 5 to 8 mLs per kilo, short I times, 0.4 to 0.6 seconds, increased respiratory rate 30 to 40, and increased PEEP to avoid over distension. So PEEPs of 10 plus. Chronic ventilation then is kind of where we come in, where these patients are over 32 weeks, usually closer to term, and we're being asked to see them and assess whether or not they need a tracheostomy and long-term ventilation. But at that point in time, larger tidal volumes of 10 to 12 mLs per kilo, longer I times of greater than 0.6 seconds, and slower respiratory rates, as well as different roles for PEEP. Potentially higher PEEPs may be actually better for some of these patients to avoid mixed matching. Next slide, please. And homegoing patient is stable on a home ventilator for a certain amount of time. This is variable dependent on center. Trained caregivers, DME equipment, home nursing arranged, and meet other criteria for discharge, which again varies depending on the center. Next slide, please. Oops, just one more slide. And then home ventilator weaning is a topic of this talk. There's really scant literature. The mean time or mean age for liberation from a ventilator is around 2.4 years, and the time to decannulation is around 3 years. But I wanted to ask, one of my questions to the group is what in general they see as their mean time for liberation from the ventilator and time to decannulation. And those are all of my slides. If we can get back to just the general slide. And then I have some questions for the panel, and please feel free to drop in questions into the chat. We'll probably just address all of the questions at the end in the chat. So to the panelists, my first question is, when does your center decide to perform tracheostomy in patients with BPD, and what criteria is used? So please feel free to shout out. Otherwise, I will pick on you. Dr. Panich, do you want to talk about how does your center at CHOP decide to perform, or when does your center decide to perform tracheostomy in patients with BPD?
As a general statement, our neonatologists start thinking about tracheostomy placement in a child who doesn't appear to have potential for weaning in the short term, somewhere between, say, 45 and 50 weeks.
Okay.
And I think there's a sliding scale. The team will talk to the family and introduce the topic. We may then regroup and, with the family's input, delay that decision or move forward a little bit faster. So there are lots of moving parts to that.
Yeah, sure. Completely agree. And I'll just pick on Dr. Mazumdar since he and I work together. But any further comments on when folks here at Pittsburgh decide on placing a tracheostomy?
So actually, I have a question for Dr. Panich. When you said 45 to 50 weeks, that's post-conceptual or postnatal?
Thank you. Post-conceptual age. Yeah, we don't wait till they're graduating high school before we decide that.
Yeah, well, 45 to 50 postnatal would be close to a year of age. I think at our center, there's considerable variation depending on the neonatologist. But I would say, as a general rule, they start thinking about it between 3 to 4 months, depending on the severity. And then they start involving us in their discussions around that time. And then depending on the various parameters, I think we end up, making the decision to put them on mechanical ventilation via tracheostomy in the next several months. I think one of the things that drives a lot of our neonatologists these days is if you're intubated, their concern is that neurologic development can be affected quite a bit. When you have a tracheostomy, they're able to interact and speak. So I think that suspect that varies a lot from center to center. I would estimate that most of our tracheostomies get placed at about 7 to 8 months or 7 to 9 months.
I'd add, this is Chris Baker from Colorado, and I would, I think I'd add that in our our ventilation, mechanical ventilation subgroup of the BPD collaborative, we've discussed timing of tracheostomy. And I think the goal of earlier often is in the child that is so dependent on the respiratory support, if they're either intubated or really stuck on non-invasive support and unstable, that we want to stabilize respiratory status so kids can start focusing more on development and being able to work with therapies and do things they can't do while they're intubated, feeding therapy. And yet there's the patients that kind of the writing's on the wall early, where even going into the 30 weeks post-menstrual age, the late 30s, closer to term gestation, they've never been extubated. They're really sick and failing. And so sometimes those kids, I think, end up with a little bit earlier tracheostomy because there's no debate about them. And there was a question in our subgroup of, should we make a metric of centers trying to have earlier tracheostomy to support mechanical ventilation, knowing that leaving a child intubated up until, say, 2 or 3 months corrected or postnatal corrected age, 2 or 3 months corrected age. So where Dr. Panich was saying 50 weeks, 52 weeks, that's a few months of developmental time after the due date when the child maybe could have benefited from earlier tracheostomy. My problem with thinking it's better to do it earlier is in my experience, the kids that the babies we have the most trouble deciding on are the ones that are in more of a gray area. They're not intubated the whole time. They're on non-invasive. They even wean to CPAP, sometimes even to high flow, and then they get sick and have a setback. And then we're giving those kids more time. And I think we should, like, to decide to put a tracheostomy in early when Dr. Redding put in the chat the question trajectory of improvement. And if they're progressing towards improvement, I'm going to give them that chance, versus if they seem stuck and we think tracheostomy would be helpful, we start those conversations, we start the decisions. And of course, the moment you bring up the conversation is usually weeks before the surgery is done. So there's a lag time there from when they actually get the trach.
Yeah, this is Jacob Kasla from Vanderbilt. We are very similar to the other three respondents so far, with the addition of we have what we've established in the last year or two is a tracheostomy evaluation team. So any patient that we think may or may not be requiring a tracheostomy in the future, whether or not they're currently intubated or like Baker said, either on CPAP, sometimes even high flow, but not the most stable. We pose it to both the family and the NICU that we are going to evaluate them for a tracheostomy, but this in no means sort of says yes or no. And that way it's a little bit of sort of a shot across the bow to everybody that we think this patient might need one. It also allows us to kind of start doing a little bit more of the social work thought process and some of the things to get them closer to home, because this evaluation team includes like a social work assessment. So we use that to start the discussions as early as we can, but from a timing perspective, very similar to what the other respondents have chimed in with.
I agree as well. We have a similar practice at Riley. Hi, I'm Ioana Cristea from Riley. So similar practice to what the other programs are doing already. Part of our decisions, yes, I agree. If a baby is close to term and clearly cannot wean, then the discussion starts earlier than later. A part of our discussions with the family, so the VEN team is trying to meet them as soon as the idea of a tracheostomy placement is being kind of raised up for a patient. And we try to explain to the parents, caregivers, what that means. So they have time to make an informed decision. Yes, the tracheostomy is not placed as soon as Baker said, takes a couple of weeks to maybe a month or so until the decision is actually made. But I think the parents need to know the consequences and the implications of having a child with the tracheostomy at home. So we are able to get palliative actually to be part of these discussions, so the parents get a sense of and get help of how to navigate this difficult decision. And I'm not going to jump ahead, Tiffany. I know you have a question on home nursing. In Indiana, we don't have many nurses, so they have to know that it's a big decision to make with many implications.
Yes, the same occurs in Pennsylvania. We don't have very many home nurses either. So it kind of leads to the next question that we had as far as what are barriers your center faces in getting patients discharged home. I'll speak for both Indiana and Pennsylvania and say nursing, but what other barriers do you guys face?
So I want to sort of add to what Ioana just said a moment ago. When we discuss tracheostomy placement with families, one of the things we stress is that it's not like the child will undergo tracheostomy placement and go home the following week. In fact, we have a training program that on average is 6 to 8 weeks. We tell families that they will have to undergo intensive training, and we try to lay out some of the things that we know that they will have to expect. Whether or not we can arrange nursing for them, we know that there will always be call outs, whether from inclement weather or illness or whatever, so that they have to understand that they will spend part of their time without skilled nursing help at home. So I think that we know that, so we already build in that amount of time from the time of, say, ventilator stability and tracheostomy placement. And then aside from arranging for home nursing, I think it's parent training. People have other things to do often besides just learning the care of their child, and we have to fit that into schedules, and people have different rates of learning. So all those things have to be factored in. And for us, the most important thing is not how fast it happens, but just that we can check off that people can demonstrate back to us the ability to care for their child. So however long that takes, it takes.
I'll put the PubMed link in the chat, but our group just this last fall published a paper by Dr. Katie Enzer, is one of our junior faculty members, that looked at our prolonged length of stay and the medical and social factors that contribute to it. And the short answer is it's complicated. You know, there's, like I used to always say, our problems is we need more home nurses. And if all we had was more home nurses, all our problems would be solved. And I think it's tricky because, you know, there's reasons why some families can woo home nurses, whether it's their social connectedness, or they live in a nice suburban home where it's kind of a cush job, or you know, the family that needs it the most is struggling financially and doesn't speak the language, or has, you know, a lot of social barriers. And so it's I think, you know, we want to, like Dr. Kaslow mentioned, try to address those up front and be as clear as possible the whole time about what this involves. And in our institution, in many institutions, all you have to sign is this one-page consent form that says, you're going to have a surgery where ENT puts a hole in your neck and sticks a tube in it, and it's a low-risk procedure, and you'll wake up, and that's what you consent to. But you're really consenting to a life of parenting a child with chronic ventilation. And I think it's important that families know upfront about all this.
At our institution, we usually do it in a kind of bipartite way. We get the child ready to be managed at settings that are manageable at home, and then they usually get transferred to a institution close by, which is classified as an acute hospital, where they get the training and they get the nursing and the respiratory equipment set up. And the shortest time it has taken them is 6 weeks. I mean, during this time, they get the nesting. And as Dr. Panich mentioned, sometimes our parents are coming to us from Erie, which is 90 minutes away. And depending on when they get time off from work, they may come in the evening, but then there's no one to train them. So that's a lot of work. And then the other thing that comes up is you have family issues where you may not have a secondary caregiver, or the secondary caregiver is not acceptable, or B, the family is at loggerheads within themselves, and that often contributes to the complexities. And as Dr. Baker mentioned, one of the bigger issues is places that have nurses. So if we have a patient that's at our place but is in West Virginia, where nursing rates are much lower, it's very hard to get them home, because all the nurses that live in West Virginia actually prefer to work in Ohio or Pennsylvania. So I think these, as others have mentioned, these issues are the largest bottlenecks in getting a patient home. And even though you may explain to a family that these are the requirements that you need at home, the relentlessness with which you need to dedicate yourself to the care of your child is really not easy for most people to understand till they actually do it. And I think that contributes to, I think, some of the difficulties in caring of these children.
Yeah, that's a very good point. Many of the lay people do not understand chronic ventilation. They may associate a vent with a nebulizer, and they say, well, that's not a big deal. I know somebody who has a nebulizer. So many times when we have these conversations with parents, we, instead of chronic vent, we use life support at home, because it is life support at home. So that makes them hopefully understand how complex this decision and process is.
Yeah, I mean, at the expense of reiterating what everyone said, we have all the same issues. The biggest ones we see are certainly caregiver. And people mention distance, and I know Baker has this problem as well, but we've got patients who live five hours away. And so when we're talking about coming to do either a 48-hour rooming in trial or to come for pieces of training, it becomes very difficult to get that hands-on. They can do as many sort of online modules or things like that about a trach change or an emergent tracheostomy change or something like that. But really, when they need to be at the bedside and be able to either be in a simulation or to do trach changes in a relatively controlled urgent situation before there's comfort, sending them 6 hours away as well.
Excellent. And so now I was going to move to kind of outpatient visits and what we do after we do finally get these patients home. So what parameters do you guys monitor during outpatient visits as you see these patients back?
Weight gain, growth, like healthy growth, stamina, milestones. We want to see that the patient is actually thriving at home. As far as other evaluations, we cannot do blood gases in outpatient. It's not that reliable. So we base our decisions many times on work of breathing, respiratory rate, SATs, need of oxygen, and bicarb on electrolyte panel.
So we fairly heavily use capnography at home for spot checks as well as oximetry. and we teach families vital signs and respiratory assessments, as everybody else on the panel does. And so both at office visits and through phone calls, we ask for respiratory assessment, including both awake and asleep, vital signs and capnography. We look for growth, so we ask for a weekly weight. We ask for feedback from therapists, et cetera. So those are all the things that we'll follow. And just to looking at the chat, Mark, Dr. Schechter asked about sim labs. We do use sim labs. I think a number of us do have simulations for families as part of their training.
Yeah, the role of capnography at home is interesting. In our 2016 home ventilator guidelines, the equipment required at home section, there was one institution, you could guess which one it was based on Dr. Panich's past comment, that routinely used the capnography at home, and the rest of us did not. Which I think there's different ways for doing that. My role has always been like I actually do use capnography at home in kids with central hypoventilation syndrome, but not for BPD. And it's just with the philosophy of I want to make sure we're having a child that's breathing comfortably, and I don't rely on end tidal or blood gas assessments to answer that question most of the time, feeling like in many cases we end up with event strategy that isn't necessarily supporting the heterogeneous lung disease of the kids. But having said that, like there is more than one way to do this. And so I feel like it's important that as programs develop their approaches, that it works where you are and that there's good follow-up. And what Dr. Christea said about the growth and development of the kids, I think we'd all would say that's our biggest marker for knowing when kids are thriving, when they might tolerate weaning, and when they need more support.
So we don't use capnography at home. We do use capnography when they come into the clinical visit. We use it particularly when we are sprinting them, and we use it more as a trend to make sure things are okay. I think one of the things to keep in mind is when there's a large leak, end-tidal CO2s can be misleading. So occasionally we will use cap gases, which are available in our outpatient clinic, and every once in a while they've been helpful. But essentially we follow what everyone else does, particularly weight, saturations, what's the FiO2 that you need, and then what are the actual pressures that you have at that time. Have we been able to bring those down? The other thing that we like to do is see what ENT is doing for them. Are you ready to use a speaking valve? When are you going to be ready to use capping? All those things are part of it. And I don't know if we don't have ENT where we see our patients, but we work fairly closely with them to get these assessments done. And I think that makes their eventual decannulation planning much easier.
Yeah, so we are lucky that we have ENT at all of our tracheostomy event visits as part of the program we've been developing. And so, yeah, to your point, our ability to get airway evaluations and plan decannulations and downsizing has been significantly improved from a coordination standpoint, having them in our clinic. Additionally, the one thing that we found very, very helpful here is using downloads from the ventilators. When we were mostly using Philips, it was very easy. It tended to all be on one central location, and when they were dedicating resources, it was quite pretty accurate. Can definitely monitor their minute ventilation, respiratory rate. You can go based on 7, 14, 30, and 90-day kind of graphs. So that would give us trends, especially when we start weaning outpatient. At nighttime, we can see if they're riding the vent, looking at percent triggered breaths. It's becoming a little bit more difficult now that the ventilator world has fractured into multiple different subsets. And so each one having their own different downloaded interface, we're not getting the same level of granular data that we were. But that was certainly assisting us in both, are we ventilate or do we appear to be ventilating well, in terms of our parameters being stable from when they were at home, and then assessing us with our weaning as an outpatient. So that's one more sort of additional thing that we're pretty aggressive with here at Vanderbilt.
I would say the same for us.
Excellent. And then how do you introduce and perform weaning or sprinting patients from the home ventilator in your outpatient clinics?
I guess I'll throw it first again. When we may get signals from a family that they have started doing little things like delaying reattaching a ventilator when it accidentally comes off, or in transfer from the bath, that, oh, after a minute or two, my child looks pretty good. That certainly is one signal. That would engender us to do the same thing in the office. And we would remove the child from ventilatory support with pulse ox and capnographic monitoring, and watch the child for several minutes. And if it looks like the child is holding his or her own, we start a weaning program of several, 15, 30 minutes, once or twice a day, depending on individual circumstances. Families will call us weekly with vital signs and an assessment of how the child's done, including weekly weights, how the child's tolerating therapy and play, so making sure the child's doing well developmentally, and that the vital signs are good. And if that works well, we advance time sequentially when the child's awake, and then we'll do that through naps, and then we do that overnight, usually hourly, until we get down to about 4 hours, after which we would stop ventilation completely. And we can do all of that at home. So you notice I haven't mentioned 3 letters in any of that, including P, S, or G. But that's our practice for most of our kids.
So we do something similar. I think the key question I like to ask is, how does your kid do when you change your tracheostomy? And if they're generally stable when they're changing, how long does it take you to change your tracheostomy? I think that's a nice signal to look for difficulty with the airway above when you're taking the trach out, if they're not doing well. And from the vent settings, you can tell if they should be doing okay or not. As a general rule, once they come down to PEEP settings of about 6 to 8, they probably should be able to tolerate sprinting. And then, like Dr. Panich mentioned, we would test them in clinic for about 5 minutes with oxygen saturation and end-tidal CO2 respiratory effort, and then put them on the plan. We do use the 3 letters that Dr. Panich avoids to establish that they're doing well. Once they're generally coming close to not being on the vent for most of the day, then we put in. I personally have been surprised by what patients have reported and what we've seen on the sleep study once in a while. I would say occasionally the patient seems, based on report, ready to get decannulated, but is not. So from not using sleep studies in the past, I do like to look at sleep studies. But I also like to work with the ENT at that time to see if the patient is capping or is using a speaking valve. And if they're capping, I find that useful in having a partially capped sleep study where you can see if there's undetected obstructive sleep apnea or other airway issues. And we find that useful in planning for obstructive sleep apnea if they're going to have that with decannulation. That's how we would do it. So I would generally don't sprint them off during the night till they have had a sleep study.
Yeah, it's similar to what we do at Vanity. Once we get to a PEEP of 8, we gradual weaning of the vent settings. We start the tricolor trial in clinic. We start with 15 minutes and then expand that at home. We also use PSG. to come off the vent. Except for those patients who are at long-term facilities. We actually have two long-term facilities where we have many patients, about probably 50 vent patients on these facilities, and there we are able to do to come off the vent with continuous pulse ox and capnography. It's a different setting, so we can do this.
At Vanderbilt, we do not often use the sleep study, given the prolonged wait that often comes with that. We again use a lot of download data just to tell, because our big concern is sort of some of these kids that have some degree of central apnea or appear to have some degree of central apnea. And when we drop our rates down, we can see how much of their triggered breaths they're getting. But prior to that, during the weaning, we use a lot of volume targeted modes. And so we're able to leave their upper limit of their pressure and then drop their lower limit or the lower pressure based on what their pips are on their download, to see, well, how much support are they truly needing? Is the vent doing most of this, or are they driving a lot of it themselves? And so that allows us to give them sort of a pop-off valve if they need that higher pip to deliver that volume when they get sick. And oftentimes we will give them a weaning setting and then a sort of sick setting being what their baseline was, so that they get sick, they can switch into that and hopefully stay at home. But otherwise, it sounds like our practice is very similar to everyone. The first one or two quote unquote official sprints is done in the office, where we talk to families. Most of them have done their own unofficial sprints at home, and that's usually one of our decision points is, have they done it? How have they done? Sometimes the answers will shock you with how long they've been doing it at home, but then it allows us to then give them a structured plan.
That's a good point, Dr. Kaslow, that like what we recommend and what families do isn't always the same. So there's certainly situations where we have to kind of get families to walk back. And, of course, we're having safety as a top priority, and yet sometimes they've made steps on their own and they show up in clinic where then I have to say, okay, like how much am I comfortable with now moving forward from where the patient's actually at, even though they didn't get there by the way I would have gotten them there. Those are tricky, and how to do all that while maintaining relationships with families and making sure that the trust is still there and the respect is still there, when sometimes like my jaw drops to the ground and I have to pick it back up and act like it never fell.
I have to say, we generally have a difficult time getting vent downloads because most of our trilogies are not with a modem. And so we are reliant on the DME company to go and get these downloads. And usually these are not easily available. It takes a lot of effort to get a download. Hopefully with the newer machines, we'll get more frequent downloads. We can see it in real time. I will say we don't use it as much as other centers seem to be using.
It took us a fair amount of, I don't want to say hounding our DMEs, but hounding our DMEs to get the ones. And so they know that anyone discharged, we are going to be asking them repeatedly if they are hooked up, if they have the ones that are accessible. And so I think now, just to get us off their back, I think they just do it as standard practice. So we had that problem initially several years ago. It's shifting a little bit. And yes, with the new ventilators, we are working with those interfaces. The companies do seem relatively open, though, to hearing feedback. So that's been encouraging as well.
We don't have hounding sensitive DME companies here, so not been able to establish that.
This is what we noticed in Indiana as well. I'm sorry, Dr. Panich. No, what I was saying, in Indiana, we have the same problem. The quality of DME company care fluctuates significantly. Even within the same company, it's regional. The care that you receive based on the part of the state is quite different.
I just wanted to go back to something that Dr. Baker mentioned, which is sometimes families take it upon themselves to come up with a weaning strategy. And often it's haphazard, so that you find, oh, well, he looked really good, so I kept him off support for 8 hours. But then 2 days later, he was tired, so we just didn't do much. And so my discussion with the family usually is, this is one thing where regimentation really is helpful. And I promise that if you follow the program, the end result will happen much faster than if on today your child looks good and tomorrow not so good. And usually with a little bit of discussion that way, I think we get buy-in. Maybe I just fool myself, I don't know, but I do think that families sort of understand we will move forward, but that our focus, we say it all the time. I bet everyone on this panel will say the same thing. Our focus is not on weaning. Our focus is on growth and development. And if weaning happens to happen, that's awesome. And we'll support that, but not at the expense of growth and development.
I have a question for the other panelists. Once you establish that the patient doesn't need a ventilator for 24 hours, do you discontinue ventilator support right away, or do you wait for a little while?
I can answer. This comes up routinely, and I do not discontinue ventilator support right away. I don't put in the order. I tell families that they've been weaning off. So my message to families is that, in our hospital, if there's a patient that's not being mechanically ventilated, that all of a sudden requires mechanical ventilation, that's acute respiratory failure. That's a ICU transfer. And so starting a kid on a ventilator is an ICU level intervention. It's also one they become used to doing every single night. So I make sure they hear from me that, like, now that we've stopped using ventilation, needing the ventilator again is a big deal. So yes, they're allowed to start it up at home. They could save their child's life by doing that. But we need to know, and probably when they call, they're going to be told to go to the emergency department. And often when those kids come in acutely ill back on the ventilator, it's at least one night in the ICU. We have a pulm floor where kids on home vents can be outside of the ICU, but I would admit to the PICU first. And then once they've declared that they're stable, get them out and get them back home. But yeah, I think it's a big deal. I let them have that ventilator up until they're decannulated, till the trache's out. And I get pushback from DME companies and from insurance. And often, if they've been away for a while, I'll let them take one of the two home vents away, but not they still have one there. So I never initiate this until the trache's out, but if it comes to me, I fight for them to be able to keep one of the home vents, even if they're off the ventilator for that reason. But I'm guessing others might have variations on that.
We have a slight variation on that theme. I would probably say 1 to 2 months. We keep the ventilator in the home. And then after that, we have the same discussion that Dr. Baker does, that requiring ventilator support is a big deal, even though the family's used to doing it, but it's a big signal for which the child needs to be evaluated. After 1 or 2 months, if someone lives quite a distance, I think that's where I would change what I'm about to say. But in general, if someone's reasonably close, I'd say 1 or 2 months later, you need to be in the hospital if your child needs that level of support here in your paragraph, so you don't need a ventilator in the home anymore.
We have the same practice. Yeah.
No, go ahead. Sorry.
No, I was going to say we have the same practice. We don't leave the vents in the home for longer than a month, maybe more if the patient lives far away from a hospital. But otherwise, when the viral season, let's say we have a patient right now who has cystic fibrosis, born early, BPD, had a beautiful sleep study. However, we still leave the vents in the home for the winter, so they have something to use if needed. But most of the other patients, we remove the vents after a month.
Yeah, I would say we tend to factor in, is it respiratory season or not, and make the call there. And then I also try to look back and see when the child had a respiratory infection in the recent few last months, how much support did the child need? So if the child ended up being admitted with a viral infection, I'm more inclined to take more time. Generally, though, once the respiratory season is over, we're a lot more pushy in getting the ventilators on. But it's nice to hear other perspectives because it's such a gray decision. It's not a black and white decision.
I did see that one of the questions, which I think is an interesting question now that the Philips company has stopped their respiratory care department, is what type of ventilator folks use at home for the majority of their patients.
And I'd be interested to kind of blow up the chat with that. I put the LP10 as a joke. No, anyone that's reading should know that that's an old vent that's not available
I
anymore.
was very impressed with your practice, Baker.
Everyone, there's so many people on this town hall that are and honestly, I was going to end with this, but it's an honor to be one of the speakers looking at who all is attending this. Like, many of you are colleagues that I've worked with or trained with, learned from, been mentored by. Really appreciate everyone that's joined onto this, and so many of you have input. But yeah, I'll say something kind of maybe a little bit scandalous, is that our main vent is still the Trilogy Evo. And it's the fact that our DME companies have them and they're supported. For the kids with BPD, I'm hoping in 2029 they don't need them anymore. And it's a moot point whether or not I have to switch them, but that's far enough out that I feel like I have time there. Of course, it's becoming less available with all the issues with Philips and Respironics. And so we are looking at some of the others. We do, I would say just not looking, we use basically all of the others as well. Yeah, and then I think maybe I have one patient still on a LTV and a handful still on the what Dr. Panich calls the legacy trilogy, the 100. But yeah.
We have a bunch on the legacy trilogies. The great majority are on the EVOs. We're part of a larger hospital system, so making changes is a very slow process because the system buys for adults and pediatrics at the same time. I think we're aiming to move to the Astro because it's approved for the smallest age. I think it has a lot more wireless capabilities of downloading data, and I think a lot of people are familiar with it already. So we're likely to be moving to the Astro. I think the legacy trilogies are going to be losing their support at the end of the year or so. And I think moving to the EVOs seems to have not been as much of a problem, but our respiratory therapists have been reporting that when they have hardware issues, it's not easy to get support. And we are hoping to get our system to move from the trilogy to another system across the system as fast as possible, because you just don't know when the bottom falls out.
So we decided to do two. We decided to do the V-Home and the Brios just so that we don't get caught out if one of them decides to abruptly end their production or use in the United States. I also see that people are asking about the Voxen, and V-Home is actually the Voxen without the other functions. So we've not run into insurance issues because it doesn't actually it doesn't have those functions, and we only use that very briefly in our neuromuscular kids who need a lot of cough assist and suctioning pretty consistently. But yes, we continue to use the Evo when we are not transitioning anybody off of the Evo. I know some facilities are actively getting away. We, like Baker, are hoping that a lot of our BPD kids can graduate from needing us prior to the expiration date of those.
We are also planning on having a secondary ventilator in our system, but we haven't quite decided on that one. I think we're waiting for some of the other ventilators to get pediatric approval and then make the decision to have at least two in place so that if one closes, suddenly the other is still available.
The thing that I would bring up is that there's a big difference between what we do on the outpatient side, which is a much more nimble, fluid process, compared with how you interface with the inpatient side, which is a behemoth of incredible inertia. And so trying to introduce new portable ventilators into a system is a big, heavy lift. So because it requires not only approval of device committees, but when we want to do downloads, it requires legal to get into HIPAA issues and data transfer. And then your inpatient respiratory therapists have to learn a new machine. If you have more than one place in your hospital where these patients live, then there's several units of people, both nursing and respiratory therapy, who have to learn different nuances of machines. So it's easy for us on the outpatient side to say, we're going to use a new device. But if that child gets hospitalized, it causes all kinds of mayhem. And so as we think about the change in the landscape because of Philips, I think everyone on this call needs to be forward thinking and asking our hospitals to become more nimble than they are. And I think one of the themes that you're hearing from everyone else on the panel is we've learned the lesson not to rely on a single maker because human nature, there will be recalls of machines. We were lucky. We had started using Astrals well before any of the recalls. And so we could pivot pretty quickly and most of the time support our kids similarly with an Astral versus either the Evo or the Legacy Trilogy. So we once again are trying to stay ahead of the curve and choose the machines that will be useful for the most. And then it's what your home care companies in the community will carry.
And I emphasize I don't have any relationship with any of these. I'm not advocating for or against using any of them. With this being about BPD, though, I will caution on the Voxen, the oxygen concentrator and the suction are on the same channel. So you have to have enough stability to be off the oxygen supplementation to suction. And it takes a few seconds to ramp it up. So it's not just like flip the switch and suction and flip it back. So the kids that are hypoxemic from their parenchymal lung disease or otherwise, I suggest some caution with that device for that reason. Although like we mentioned, the kids that need cough assist, that device can be really helpful to get cough assist while being ventilated on the same machine. The Vivo 45 LS is like the smallest one, and families seem to really like that one. The Astral has some nice modes for chronic lung disease, including what has been mentioned, the pressure support with a safety volume. That's basically the volume target pressure support, or what we called AVAPs on the Respironics devices. So I feel like they all have some benefits. They're all nice machines, and yet having a one that your system knows there's a huge benefit to that.
Yeah, I think it's a challenge that we're all going through right now. And my last question before we take chat questions, if we have some time, although I know it's almost 4 o'clock, but what do you tell families about long-term outcomes? For example, expected duration of ventilation, time to decannulation. I know that's kind of a big question.
Dr. Christea, I quote your paper, so if you want to talk about it.
So I think it depends on the patient. If the patient has BPD and no other comorbidities, yes, I would still go by the first paper saying coming off the vent around 2 years, give or take, and decannulation 6 months after, assuming no RA problems. But if the kid has any other problems, cardiac, you name it, it's probably taking longer. That's my short answer.
Yep, we're the same. We also caution that if we're coming off during, in November or December, there may be a little bit of a slowdown in terms of the weaning process. We also don't like to decannulate in the middle of winter if we can avoid it, just historically. So the timing of that can sometimes change, but we always say it's not our show, right? It's the kids. They're running all of this. We're just here to support them, and so it gives us a little bit of wiggle room to change things as necessary.
Awesome, perfect. Thank you guys so much. I didn't know if there was any other questions in the chat that we did not address.
Hey, this is Matt Wong speaking. Yeah, there are a couple questions in the chat. So that we have one from Dr. Rose. And the question is, what is your vent mode of choice and how does that inform your approach to weaning of settings?
Well, like I mentioned, we use a lot of pressure support with some sort of assured, either AVAPs or some sort of safety tidal volume. We can pull kind of what volumes they're getting on the ventilator inpatient and then transition those. And then we try to keep that mLs per kilo going while we're outpatient. It also just gives them a minimum volume and allows us to have a large pop off if they get sick so that their PIPs can rise, but that we can lower their pressure support range so that if they need less support, they're getting less. And it helps them sort of slowly wean off. We've had pretty good success with that.
We use a similar approach to Dr. Kaslow, but for kids who have more severe disease who require higher pressures that the ventilator may not be able to deliver, we need to use a SIMV and volume control mode with pressure support. Otherwise, we can't transition to a portable ventilator. So you can achieve higher pressures in a volume control mode with these machines than you can in a pressure control mode. So sometimes the disease of the patient dictates the mode that you'll have to use.
I agree with that. The kind of volume control SIMV gives the ability to apply what I guess I could describe as kind of a supportive or chronic strategy for ventilation that probably is best outlined in a paper. Steve Abman, he's I think signed on here, but he's the first author on a 2017 paper in Journal of Pediatrics about the BPD collaborative's interdisciplinary approach for BPD. And it describes that kind of chronic ventilatory strategy of optimally ventilating the heterogeneous lung. And you could do that nicely when you're in control of the tidal volume and the inspiratory time. And then most importantly, being able to keep the rate low so that there's time to exhale. Then in the volume targeted pressure support modes like AVAPs, the patients describe or decide their own rates. And that's a downside, although I will say it's such a comfortable mode that we've seen spontaneous respiratory rates of patients drop dramatically. So we use a lot of AVAPs or volume target pressure support, and it's for that reason. And yet trying to keep in mind the appropriate I won't even say appropriate, but just the strategy that's targeting the pathophysiology of the severe BPD lung.
We have another question from Dr. Redding. Do you have a protocol for changing from inpatient ICU to home ventilators?
We don't have a specific protocol at our end. It's usually done in ICU.
I think for us, we make sure that the child has achieved stability on ventilator settings on the ICU ventilator, and I think after that, it's sort of individualized.
There are institutions that have published vent setting criteria like FiO2s or PEEPs for transitioning, and we don't have those. Really, the home vent has to be able to copy the vent strategy that's working on the ICU ventilator in the NICU, or I guess PICU in some places. And if that can be done, we try to make that transition when a child's stable. And then we do have a criteria for leaving the intensive care unit generally of an FiO2 below 50%. We don't have a PEEP maximum for our floor, just like we don't have a PEEP maximum for our home. But other institutions do and have published that.
Yeah, there's a pretty expansive transition plan that came out of Arkansas in 2020. I put it in the chat as a response to that. Dr. Aguilar there has a pretty robust transition plan that they use involving gases and assessments and readiness and what a failure looks like or doesn't. And it's been helpful to sort of formulate some of the framework that we use, although nothing official.
I agree. That paper involved the LTV, older pulmonetics ventilator, and a PEEP maximum that I wouldn't go by, but it was the one of the ones I was thinking of too. So thanks for sharing that, Jacob.
I think we can do one final question, just out of respect for time. This one's from Dr. Kufer. Understanding that the EVO will be supported for several more years, how do you think about continuing to use the EVO while there are unclarified safety concerns about Philips devices in general?
I think from our perspective, moving from the EVO to something else, because of the reasons that Dr. Panich mentioned, where it's a large system, we need to make sure that the inpatient respiratory therapists are as prepared as the outpatient therapist, is also a slow decision. And so I think there are downsides on both ends. And so we're moving slowly but surely towards transitioning it out, but recognizing that there are issues to moving fast.
Okay, I see that it's a little bit after 4 o'clock. Thank you guys so much for all the great questions. Thanks to the panelists for making this such a successful town hall.
Thanks to everyone for joining
Take care
us.
all. Thank
Yeah.
you.
Thanks for having me.
Thank you guys.
Bye.
Thank you, Tiffany.